Welcome, everyone, to today's webinar on achievements in EHE. Today's webinar is the final in a series of 4 webinars. And today we'll be discussing building HIV program sustainability through blended funding. So we'll be hearing from 2 EHE health departments today on their efforts to blend or braid funding. And we'll have time for Q&A and discussion at the end. Feel free to use the Q&A and chat function at any time to ask your questions or put in comments. And we are recording, so we will be sharing the slides and the recording through NASDAD's website, as well as via email to everyone who registered. So just before we get started, just for folks who may not be aware, NASDAD is the National Technical Assistance Provider for EHE. And so we are continually available to support health departments and CBOs in EHE jurisdictions, both funded through CDC and HRSA. And I'll be putting the link for our website in the chat briefly, but we encourage you to check that out. There are a lot of great resources on there, as well as information on how to request technical assistance. So before we get into our presentations, we wanted to just take a little bit of time to ask you all what you're doing in terms of blending funding. So what you can do is either scan the QR code using your cell phone camera, or you can open up a new tab on your computer and go to menti.com and put in this code 5415757, and I'll also put that in the chat. And there are 2 questions that we're asking you all, and that is if you all are currently blending funding for your HIV prevention and or care programs, and if so, what funds are being utilized and for which services? So we'll just give folks another minute to answer those questions, and we'll stop the poll, but feel free to also continue to put things in the chat. So far, lots of folks say they are blending or braiding funding. And the next question, what funds are being utilized and for which activities? I'm seeing HRSA and CDC for status neutral low barrier clinics, care navigation, Ryan White rebates for HIV testing, CDC only testing education cluster detection, state funds for PrEP medical assistance. All right, feel free to keep adding to those, and you can also add your answers to the chat. Just for time's sake, I'm going to go ahead and move on to our presentations. I'm going to stop sharing. And so I'm going to give our presenter from the Arkansas Department of Health to introduce themselves and to share with us a little bit what they're doing in Arkansas.
Hello. So my name is Zakosha Watson, and I am the EHE Grants Manager. I've been with the agency for going on about 5 years. Under the EHE program, I've pretty much held every role. So I was a data and links to care coordinator, and then I went to the EHE coordinator, and then the EHE coordinator / field operations manager, and now the grant manager. And so here in Arkansas, basically our team, we are still just trying to engage with clients that we find to be out of care. That's one of our primary focuses that we do. We focus on clients that have been out of care or need to be re-engaged in care. Our data and linkage to care team, that is their primary role, which we'll discuss that more as I go through my presentation. And then we have our health intervention investigators team, which are the traditional DIS. And so they interact and engage with clients that come into the local health units that test positive. So that's currently what we're doing here. We do have a statewide transportation program. So our transportation program, basically we use blended funding for it. We can transport clients to their medical appointments. We can transport them to appointments for supportive services. So if they're needing to go sign up for insurance and different things of that nature, then we have one of our community-based organizations that provides that transportation throughout the entire state. And I will say that has been a turning point for our program in terms of alleviating that barrier for clients, just knowing that they do have adequate transportation to get back and forth to their appointments. So I guess I'll go on into the presentation. So our program mission, of course, as with EHE, is to reduce the new infections 75% by 2025 and 90% by 2030. And so to do this, we know that we have to focus on the pillars: diagnose, treat, prevent, and respond. But we also have to be innovative and comprehensive in our approach to be able to navigate those pillars. Next slide, please. So when we look at our organizational structure, this is just kind of an outline. So we have our branch chief, then we have myself as the grants manager, and then I have a supervisor and a manager under me. The supervisor is over the health intervention investigators, which, like I said, those are our traditional DIS. They handle all new HIV cases for the entire state of Arkansas. They do sit in local health units, so it makes it a lot easier for them to be able to engage with those clients on that initial diagnosis, I would say, or preliminary diagnosis of them being able to get the HIV diagnosis. And from there, then our team works to get them into an expedited medical appointment so that we can get them on medication. Same with the data and links to care team. We have 5 data and links to care coordinators that sit here on site. And then we have that manager. The program coordinator and the field ops manager, they're over our community-based organizations. So currently we have 4 community-based organizations. That's Future Builders, EAC, and Starlight and UAMS. And then they also manage our public health service agreements, which we'll go more in detail about later. So our data and links to care team, they identify and locate those not in care. So the not in care list is generated from our state epidemiology team. It's a list that we get every quarter. So On that list, it basically outlines any person that had a previous diagnosis of HIV and has not had any recent labs completed within the last 12 months. So it goes beyond the 12 months, but the 12 months, we consider those to be priority because we look at those, they possibly just fell out of care, to be easier to re-engage those into care as compared to someone that's been out of care 24 months or longer. So we get that list. And then, of course, the cases, they're reported through our EHE system as well. And then the data and links to care team, they reach out to those clients. They try to provide guidance. So building that rapport with the client, letting them know that we're there to assist them. We want to make sure that they get into the medical treatment and services that they need. And also informing the clients and connecting them to any additional resources or supportive services that they may need. Our health intervention investigators, so they investigate 90% of newly diagnosed cases. Like I said, they pretty much deal with all the HIV cases that come through the local health units. And then they provide them with the services, get them in for expedited appointment. Of course, they do their partner services, see if there's any additional persons that we may need to identify for medical treatment and services, get them in for treatment if needed. In the event that the patient needs transportation to their appointment, of course, they can provide transportation assistance. And then our health intervention investigators, they also go out and participate with our community-based organizations, just being on site at some of their events so that the community can get a feel for them, understand who they are, their role, and how they can be of assistance to those that may need our services. So these are the areas throughout the state. The northeast area is basically the only area, northwest, I'm sorry, is the only area where we don't currently have a health intervention investigator. The other 4 areas of the state are covered. However, we are looking at putting a health intervention investigator in the northwest area as well. That's the only area where we currently don't have one, but the local health department up in that area, they work very diligently with our health intervention investigators to ensure that we do get all newly diagnosed cases for expedited services. So we also currently have our community health workers. So our community health workers, they sit in the same counties where the health intervention investigators sit. And basically what happens is once our data and links to care team or one of our health intervention investigators has been able to make successful contact with the client, link that client into care, meaning we've gotten them into an expedited appointment, on medication, or the medication is in transit to them, then upon the approval of the client, we will partner them with a community health worker or a non-medical case manager. Well, this is for the case manager supervisor. So these are the individuals that are over the actual community health workers. They do the needs assessment, so they provide that non-medical, medical case management, and they also assist with supportive services. So upon doing that intake, they do a thorough needs assessment, not just to see if the person is needing assistance with HIV related services, but any additional services that they may need assistance with, because we want to take care of the whole person. Our community health workers, so these are the ones that they go out, and these are individuals that have like experiences or are able to relate to some of our clients. They assist with treatment services and resources to sustain engagement and care, provide psychosocial and emotional support for the client. They also link the client to additional resources in the community. additional resources for their basic needs. And then they can also transport the clients to and from medical appointments as needed, as well as other supportive services appointments. So maybe if the client needs assistance with going to get their light bill paid or something of that nature, sign up for insurance, whatever the case may be, as long as it's a supportive services that's going to alleviate a barrier, a basic barrier for that client, then that is what they're able to do. And then we have our community-based organizations. Our community-based organizations, our positive miles transportation service, of course, this is CDC and HRSA funded. And so this is the program that provides statewide transportation. So no matter where the client is throughout the state, no matter where we're able to reach them at, we can get someone from our positive miles team to transport them to an appointment. As we all know, the stigma associated with HIV, a lot of time clients don't want to go to medical appointments in their home area. So a lot of times, Little Rock being the central area of the state, a lot of times they'll come up to Little Rock for their appointment. So our positive miles team is based here out of Little Rock. So if they have to go back to Southeast or Southwest Arkansas, that can be an hour and a half, 2-hour drive there to pick up the client, to bring the client up here to their appointment and then back. So the transportation, it can be kind of lengthy in terms of the ride sometimes, but they have been very great with ensuring that they get our clients into their appointments, confirm those appointments in terms of those rides. And we're looking at innovative ways to where we can just make that process, kind of streamline that process a little bit, maybe possibly have where our riders can track their drivers as they're on the way to their location. So we're just looking at ways to be more innovative and be able to measure the data from the services that are being provided through our transportation piece. Again, our community health workers, the psychosocial support, I think that's really big for our clients. Linkage to care. So we get them into the medical care and treatment services, but they also assist them with getting linked to other additional services as well, additional supportive services, I would say. And then they evaluate the client's complaints with medical appointments. So we have had some clients that complain about their medical appointments, providers not being culturally competent, to be able to assist our clients. So those are things that they work on the client with, take that feedback from the client, bring it to us, and then we try to work with those providers or whoever those other partners are to ensure that the client has a pleasurable experience while dealing or while receiving treatment at that facility. Short-term assistance, supportive services for maintaining positive health outcomes. So the community health workers, they typically work with them for up to 6 months. During that 6-month period, we're just trying to really get them in the notion of understanding their diagnosis, understanding how important them staying in care is, following up on their labs, making sure that they're taking their medication before we transition them over to the Ron White program, because that is the ultimate goal, to get them on the Ron White program. Again, this is just our community-based organizations and some of the services that they provide. So initial assessment of needs. They develop an individualized care plan. So based on the feedback that they receive from the actual client, they will create a care plan that they will work, set goals for the client, help the client to achieve those goals. They'll coordinate medical care access, support services, and continuity of care. And then coordinate utilization of services, ongoing client monitoring for care plan efficacy, and they would reevaluate the plan periodically. So when that initial plan is developed, the client has goals that they allow the clients to set their own goals. The community health worker assists the clients with achieving those goals. And as we go through that process of working with that client, the plan is reevaluated, see if we may need to maybe update some of the goals or rearrange some of the goals. If we need to retain that client longer, just to make sure that we're able to get them to a point to where we feel comfortable with them being successful on the Ron White program and remaining compliant and in care. Again, so as I stated, just the same thing, supportive services, short-term assistance for maintaining positive health outcomes, compliance for medical appointments, linkage to care, and psychosocial support. So these are the direct actions of our community health workers. The data that links to care, this is their workflow process. So the first step is going to be research and review. So they have various systems that they utilize for being able to find updated contact information, addresses for clients that show up on our not in care list. If for some reason EHARS or PRISM is not up to date with that contact information, they can utilize those services, Spokio, whatever system we need to use to be able to get updated information, even if it's just the address, such as Spokio or something like that. We send out a generic letter, nothing specific regarding HIV, just that we need to speak with you regarding an important health matter. If they are able to make successful contact with the client, then we'll talk to the client, see if they, when was the last time they've been to the doctor for labs. We'll assist them with scheduling that appointment, confirming that appointment, seeing if they need assistance with transportation. If they need assistance with transportation, of course, we're going to make sure that they get there. Even if one of the data and links to care people have to transport them themselves, they're going to make sure that they get to that appointment. And then once we've gotten them into their appointment, we've gotten them their medication, then we want to see what additional services do you need assistance with? What, it could be housing, it could be maybe possible utility assistance, anything that we can look at to ensure that we're able to let them know that we're there for them, but also build that rapport and alleviate barriers from them that would deter them from not being into care or not going to their appointment, not taking their medication, just whatever we can do to deter them from not staying active in their care. And then, of course, as I stated, the ultimate goal, once we have had the client, is to transition them over to the Ron White Part B for continuity of care so that they can get medical, mental health, and dental services, as well as prescription drug assistance. And so this is the process, the workflow process for our health intervention investigators, which is also our DIS. Process basically looks the same as the data and links to care. However, they do go a little bit more in depth because in the event that a client comes in that is tested positive, then of course from there they have to see who the partners were, and then reach out to those partners to possibly get them in for testing and as well go through our standard process of linking them into care and getting them on medication. So coordination of other funding. So again, like I said, our program does receive CDC funding and HRSA funding. The Starlight Foundation is one of our CBOs that is strictly CDC funded. And so they complete HIV testing and education to persons aged 15 to 65 years old. And that's just by going out into the community, engaging, participating in community events. With a focus on Southwest Arkansas. So Southwest Arkansas is a very rural area with limited resources. So being able to engage and participate in events down there and bring awareness not only to the EHE program, but to HIV resources and services that has been, especially for this organization, because this organization has been around for a while. So that just having that presence out there under EHE has been very impactful for some of the people that we've served. Next slide. Okay. UAMS, so the University of Arkansas for Medical Sciences, they are a sub-grantee that's funded through CDC funding as well. Their service areas are going to be Southeast, Southwest, and Central public health regions. So of course they do the social media campaign. They also have the advertising. So they have a billboard that they rent a billboard. I think maybe like every 60 to 90 days, they move it from county to county throughout their area. with PrEP. So their focus is going to be on PrEP. They also do on-site HIV testing, education and public health awareness on methods for preventing HIV. They can do telehealth medical appointments with physicians offering PrEP care. They can provide transportation to PrEP providers for PrEP care. And they also promote HIV testing and education through faith-based organizations. So their focus is pretty much on PrEP, but they do HIV testing as well. We also have an initiative, Take Me Home. And so with the Take Me Home, we have a site that interested persons can go to. They can order a test kit online. The test kit is sent to them at no cost, so that they can perform those tests. We also have information where they can send the test back, and further actions that are needed if the test is positive. So this brings me to the case for the public health service agreement. So all of that is the way our program is structured. But of course, without having our public health service agreements in place, we wouldn't be able to get our clients into our expedited appointments. We wouldn't be able to get them their medications. So our public health service agreements have been very pivotal for our program. Our public health service agreements are agreements that we have with medical providers throughout the state. Under our public health service agreements, one thing that we wanted to do, or that we requested from the providers that we establish these agreements or partnerships with, is we asked for expedited appointments. What we were finding when we initially started the data and links to care process was that we would make contact with the client, and upon making contact with the client, again, getting the client agreement to go to an appointment, well, we would have the appointment, the provider would only be able to give us an appointment maybe 5 to 7 days out. Well, by that time, for whatever reason, we've lost contact with that client. The client's not answering the phone anymore, or whatever the case may be. But with the agreement that we have now, they agree to give us an appointment within 24 to 48 hours. That has been very successful for our program. We will transport the client if needed, and we work around the client's schedule for that scheduling. So if the client can't make it within 24 to 48 hours, we don't hold that provider. Responsible for that, because they did have that opening for us. It was just that the client was not able to make it during that time. So as long as they're able to get us into the next available appointment, we're good with that, as long as it meets the client's needs. So what is a public health service agreement? It's a contract, it's a guide. So it provides insight to services that comply with the public health service treatment guidelines. It outlines services requirements and responsibilities of participating providers and facilities. So case note, lab test result, billing practices, site audits, all of that is outlined within the public health service agreement. We also provide them with a manual that outlines the program, the goal, the mission of the program, labs, tests, how we expect case notes to be, billing practices, where bills to be sent to. So all of that is in the manual, and the manual is sent out with the public health service agreement for review. So the benefits that we found for the public health service agreement, it allows us to coordinate care for the program's priority populations and protocol among organizations. It explains covered and non-covered services and data sharing procedures, and it details compliance. So state and federal laws, non-discrimination laws, debarment and suspension, access to records, client confidentiality. So basically it allows the Arkansas Department of Health and the provider to know, basically just to lay it out, what's expected, what's not, what we're looking for, the population that you'll be serving, the services that you can provide that we will reimburse you for, and then at the same time, the state and federal laws. So non-discriminatory, debarment, all of that, it allows us to be able to lay that out on the forefront for the provider, is a determining factor as to whether or not they would like to be a EHE provider. Locating providers for public health service agreement. So this has been, and I think will continue to be a challenge for our program. However, up on our initial process for establishing our EHE network of providers, we basically piggybacked off of the back of the Ron White program. So I used to be the Ron White HOPWA coordinator, and so I was responsible for managing that network. So I reached out to a lot of those that I know were already providing HIV services and treatment, and we explained our program to them. We, asked for those expedited appointments. We also, I do want to point out as well, for our expedited appointments, for all providers that are able to give us an expedited appointment, which is that 24 to 48-hour time frame, we do provide them with an incentive for being able to provide us that appointment. Like I said in the previous example, now if it's for whatever reason, if the client cannot make it within 24 to 48 hours, then we do not hold that against the provider. We will still provide them with that incentive because they did have that slot available for us. If it goes beyond that 24 to 48 hours, then we do not provide that incentive if that's based off of the provider's current scheduling. So back to locating our providers, we piggybacked off of the Ron White providers list. We did get some good responses. I do think that us actually going out and talk to the providers ourselves helped to provide the providers with a better understanding of what EHE is and what our purpose is and our goals is, because what we were finding was when we sent the contracts out, we were sending ours out at the same time Ron White was, and it was basically like they thought they were getting duplicate contracts. So some we didn't get back, some we had to go back and send those out again. Myself or either my coordinator, we had to go out to those providers' offices and break our program down, explain it to them, and that allowed us to have a better understanding. With our public health service agreements, we also have so a lot of times what we found too was that when we send out the public health service agreements within the medical providers' offices, either they're going to go to the billing team or they're going to go maybe to like upper management, and it never trickles down to the billing team. So when we call in for expedited appointment, they're like, no, we don't, So what we did, we met with some of the leadership at these providers' offices, and we asked for a direct point of contact. So someone that would be familiar with our program, someone that would understand when we call in, we're looking for expedited appointment. Once we send the referral over to you, this is basically saying that you're agreeing to give us that appointment within 24 to 48 hours, as well as we're agreeing to give you the incentive. So the incentive for them being able to provide our clients with expedited appointments within 24 to 48 hours, I want to say it's $90 for them to be able to, because basically they're holding a slot for us. And so we provide them with the incentive for being able to provide us with those appointments. And then we're still recruiting providers, providers that we see that may come up, like when we talk to our clients and they, maybe we have 2 or 3 clients that go to one provider, or, they want to go to the same provider. Then at that point, we'll try to get someone from our team, whether it's the data links to care, our health intervention investigators, we'll try to get someone from that team to go out and try to recruit that provider as one of our EHE providers. Next slide, please. So the credentialing and enrollment for the public health service agreement, as I said, we'll go out, we'll meet the provider, explain the program, goal, mission, we'll answer any questions that they may have. We always try to make a clear and concise distinction between EHE and the Ron White program, because we've noticed as well that sometimes when EHE claims are sent in, they're sent into the Ron White program, and we have to go through and kind of clean that up once those claims and so forth come in. So we try to make a clear distinction in terms of we have a referral form that we send over to that provider. Once we're referring someone over there, once we've spoken to who we need to speak to on the phone to get that appointment, then we send that referral form over, letting them know, hey, this is confirmation, we spoke, this is the appointment. As long as we're able to get this client in within the 24 to 48 hours, we're going to give that incentive as well as for that office visit. So that has helped a lot as well. We will go through any policies and procedures that they may have questions about in the provider's policy and procedures guide. I like to take the billing person out there with me, as well, which is typically my coordinator, so that they can answer any questions about submitting claims, how to submit those claims, what we're looking for when submitting claims, and then just let them know if they have any questions about submitting claims or how to submit claims to just, reach out to us. We'll be more than happy to assist them. We also verify their license and their DEA certification. And then just go through the public health service agreement and answer any questions that they may have about the public health service agreement, that may not possibly just stand out upon initially reading it, but we will be more than happy to answer any of those questions that they have. And so then, of course, with gaining providers, then of course we have to maintain those relationships. And so we have to maintain those relationships. We have to make sure that they stay aware or culturally competent of the clients that we're sending into them. And of course, we look at offering trainings, case management for HIV CME for HIV case management, provide updates on covered medical services and meds. So from time to time, there may be additional services that we're going to cover. There may be additional medications that we're going to cover for that client. And then provide program updates and any changes, challenges, or barriers to servicing clients. I know that with a lot of our providers, we did try to have like a lunch and learn session, where we could go through, the bullets here in this email with those providers. And it became difficult, because a lot of the providers, they weren't able, maybe seeing patients and so forth. But that is something that we want to get back to, even if it's just a matter of us sending out a newsletter to those providers, letting them know updates and things that we have changed within the program. Now we do have, as we go through our new work plan, we do have it set up to where, or we're going to incorporate to where any EHE provider must go through at least one training that we offer per year. And that's just to make sure that they're, you know, understand what our goal is, what our mission is, how we expect our patients to be treated when they come into their office. And then for any questions or concerns that they may have for us. So just making sure that everyone that's serving our clients are on the same page when it comes to providing that medical treatment and services. And so that's pretty much how our program works here. For our public health service agreements, like I said, we do utilize blended funding. So any questions?
Thank you so much. There's a couple of questions in the chat. If you could answer those in the chat, that would be great. I want to just be mindful of time and have our colleagues from the San Francisco Department of Public Health share about what they're doing. So I'm going to pass it on to Andy and Thomas.
All right, thank you. Get my screen shared here. And away we'll go. Okay, you can all see my PowerPoint?
Yes, we can see it.
Fantastic. All right, well, thank you for having us here today. And thank you, Zakosha, for your presentation about your program. It's great to hear about the work that's going on there in Arkansas. So we're going to talk to you a little bit today about our blended funding initiative, blended funding, braided funding. I think we're hearing them kind of both of those terms. But first we'll start off just by giving a little bit of an overview of our two different branches here at the Department of Public Health that are working on HIV care and HIV prevention. So Thomas, do you want to talk about CHEP a little bit?
Yeah, so I work in the Community Health Equity and Promotion branch. Our role primarily is just working with community-based organizations around any kind of prevention activities, traditionally, and that includes smoking and safe routes to school, things along those lines. So it traditionally was the HIV prevention branch back then, but the department a number of years ago decided to kind of move all of those community efforts into one entity. And then specifically for this space, the ending the epidemics efforts with regards to HIV, Hep C, and STI and overdose endemics, kind of pulling all of it together. Thanks, Andy.
And so for HIV Health Services, which is the branch that I'm in, we are the ones that administer HRSA, HIV/AIDS Bureau funding, so the Ryan White funding, all different parts. And we primarily focus on medical care and wraparound support services, of course, solely for people who are HIV positive, and we're the ones that are the HRSA HAB ending the epidemic. Dollars are coming through our department for HIV care side of things. And then Thomas can talk a little bit about CHEP's population of focus under the prevention EHE work.
Yeah, so when we, with our ETE funding, we focused on the populations that are on the screen here, just with regards to the fact that they were looking at our data-driven approach and the fact that there was either these were populations that we weren't previously focusing on, or we were focusing on still had significant disparities continuing. So we wanted to take the additional funds and make sure we could do it. We wanted to address that. Thank you.
And so for the HIV Health Services side of things, we focused on some specific populations, focusing on transgender women, people who are experiencing homelessness, those who are justice involved, and then across all of the priority populations that we have, of course, we're seeing substance use being an issue as challenging to viral suppression. We're seeing that across all of our priority populations. And this slide is just a little bit of the peek at the gains that we've made with viral suppression equity among our priority population. And we're achieving these through the increase of intensive care navigation services and case management, through low barrier care site, really trying to increase the amount of low barrier care sites that we have available to clients, and also through long-acting injectable ART, which is something that we're going to talk a little bit more about today. So before ETE, EHE, and I say ETE, EHE because on the prevention side, it is a syndemic approach. So looking not only at HIV prevention, but STI and substance user health, so ending the epidemic. But on the care side, we're ending the HIV epidemic, so just solely focused on HIV care engagement. So before ETE, EHE came along, of course, we had collaboration through the Community Planning Council, which is the blended care and prevention councils. We have a test and treat strategy that's been in existence in San Francisco for quite some time. Of course, U equals U, otherwise known as prevention with positives, is a lot of the work that we do. And we also fund many of the same agencies. And then once we moved into the EHE, ETE environment, we've really made strides to increase care and prevention navigation. So in a status neutral type of service delivery way. And then I think that there's been increase in cross branch collaboration under the EHE environment. We took a stab at braided funding in a contingency management program, and we found that it was very challenging to do for many reasons, and we talked about that in a previous presentation through NASDAQ. So one thing that came up for us in the EHE environment was that there is a huge rollout happening of long-acting injectable ART, and both for treatment and for prevention. And Thomas and I felt that we absolutely are here supporting these programs, supporting the rollout of LAI. And a lot of this work is coming out of the EHE and the ETE programs. And at the same time, we were kind of unsure a little bit what is our current state, and what does the community see as the goal that we're hoping to reach with LAI ART? What is the future state that we all desire to have? And so this is an effort that we blended funding to do a landscape analysis about LAI, ART, and PrEP rollout. And we were kind of inspired by all of the previous interventions that had happened in San Francisco on the way to getting us to the numbers that we're at right now with our new diagnoses. All of these different interventions through the city really took concerted and coordinated effort to implement. And we feel that LAI, ART, and PrEP is just the latest one. And so we set forth at trying to figure out, okay, what is the consensus around where we are today and where do we want to be in the future? And so for that, we did this landscape analysis. So you'll see the purpose here on the screen: assess the current state and really identify what are the facilitators and key barriers to reaching an envisioned future state. Of course, anytime that we do something like this, we need to identify, okay, what is the procurement options for this landscape analysis? How are we going to achieve this? And so, fortunately, on the HRSA side and the HIV Health Services side, we had set aside a little bit of unobligated balance for some consultancy work. We knew we needed to have a consultant support us with some things, but we didn't know exactly what we needed to have them support us with. So we had that set aside. And CHEP, fortunately, has already had an existing contract with a consultant that we all here in the Department of Public Health trust and have worked on a lot for our EHE work. And so we were able to piggyback on the existing contract with that consultant for blending our funding, both for the existing work that CHEP was already doing and then adding on some funding from the HRSA side to fund this work. There were a lot of cross-branch planning and implementation meetings, and those were both headed up by Thomas and me. And then we also, during those planning meetings, did a lot of work to really do warm handoffs so that providers that were going to be interviewed for these efforts knew that we were embarking upon this effort, and also that they would respond to our consultant who was conducting these interviews. So just a little bit of an overview of the landscape analysis that our consultant did. So interviews with sites that were doing long-acting injectable, both for ART and for PrEP. They also looked at some supplemental data on LAI uptake and reviewed the relevant literature and materials. So you see, we were primarily a qualitative approach to this work, although there was some quantitative data collection and, of course, the literature review of relevant materials. And what was found were four main takeaways with this landscape analysis. The first was the acceptability of LAI, ART, and LAI PrEP. So patients generally find it to be an acceptable intervention. Some concerns were highlighted, and these concerns that were highlighted were something that really helps all of us involved in LAI implementation understand where we need to focus our work. Many of the folks interviewed, many of the programs emphasize that their approach to LAI has had an equity lens to it. So from the start, they've really focused on reaching populations who face barriers to oral medication adherence. So people experiencing homelessness, people who use drugs, and other groups that have lower viral suppression rates. In current state, where we feel we're still rolling out this intervention, programs stated that they required considerable time and skill for patient navigation support, follow-up between injections, and also for insurance navigation. Now, that's in current state, and we do see progress being made in terms of the resource intensiveness diminishing a little bit. But we are trying to still figure out, okay, in future state, how much of the resources are going to be required in order to implement programs in the way that we want to see them implemented. Another one of the takeaways from the landscape analysis was scalability and sustainability. So sites had a lot of really innovative ideas for how to scale their LAI programs and how to do it in an equitable manner. And they all felt like they lacked sufficient dedicated resources for LAI. So at the time of the interviews, which was last fall, really some had already capped or planned to cap participation, and they would require additional resources to expand their programs. This blended funding activity also gave us an idea of how the LAI programs are structured. And really the big picture takeaway that we got was that there's no single standardized way to run an LAI program in San Francisco. That structure really varies based on the organization type, the resources available, staffing available, and also, of course, the patient population that's being served. So our big takeaways from this landscape analysis was that LAI is one of many tools that we have for ending the HIV epidemic. Scale is limited. It depends on the resource intensiveness of the programs there, and these programs are oftentimes resource intensive, at least in current state. There are potentials for large equity gains. So when we're targeting priority populations that have traditionally seen challenges in oral medication, seen lack of equity in terms of viral suppression, and that we see disproportionate new diagnoses, and there's a potential for us to make gains with these communities. New partnerships are something that would be very beneficial to programs, and so that's something else that helped us to understand we need to explore and develop. And then also, of course, we need to do evaluation of these programs to really fully understand their impact. And there we are with 5 minutes left to spare for any questions that people might have.
Thank you so much. I'm not seeing, I think all the questions in the chat were answered, but I did have a question for you all and for Zakaria as well. Can you all talk a little bit about what you've seen are the benefits of blending funding and then some of the challenges that you all have encountered?
I think one of the greatest benefit that we have had with being able to utilize blended funding has been we utilize blended funding for our transportation piece. So we use CDC and HRSA funding for that. We also use it for our medication. So we have a contractual agreement with a pharmacy that basically once the patient is given their script, is sent over to them, they'll mail that medication out to them. So those have been two of the greatest successes I've seen with us having the blended funding. Some of the challenges, I would say, I don't know what our greatest challenge has been. I guess just utilizing the funding to make sure that, sometimes you'll be like, well, we can possibly cover this under HRSA. Well, no, HRSA doesn't do that. They're treat and respond. Well, we maybe do it under CDC, and just kind of being in limbo between the two, I would say, on different things. One thing I do want to say Oh, another thing that I will say that our funding has allowed for us to do, now this is strictly HRSA funding though, but under our HRSA funding, it has allowed us to be able to provide emergency financial assistance. And so with our emergency financial assistance, what that is we can assist with rental payments, housing payments, utilities assistance, different things like that that may potentially become barriers or cause the client to, you know, they're not thinking about getting into a care or going to a doctor's appointment if they're about to get evicted or something like that. So that has been a huge success for our program as well.
And do you want to speak to this? Or you want me to?
Yeah, I mean, I think that one of the benefits, I think one of the great things that we've seen happen with the blended funding is to really focus us on trying to find ways for us to blend funding. There's been a lot of talk of status neutral services, and it's really pushed us into that environment, I think, a little bit more. And even with that, though, there are challenges regarding, asking workers to do this kind of blended funding work. I mean, people, one of the things that we see oftentimes is that people are mission driven. They're drawn to doing one type of work. And so if you're drawn to doing work with people who are newly HIV positive or with reentry into care for HIV, and that's your passion, it's going to be hard to pull people into prevention environments. And similarly, some of these systems are quite complex, and you need to specialize. So if you're talking about benefits navigation for people with HIV, that is a very specific environment and it's a specialty. So then throwing something else on top of that can get really challenging, and I think makes it hard to then be practical and be able to execute without really burning out frontline workers. So it's just something that we can't afford at this point. Thomas, anything you'd like to add in there?
No, just kind of acknowledging the funding requirements are different. So just with the documentation around the HRSA side, it's much more substantial. So in some ways, it's a benefit that we have the CDC flexibility where it's only leaning into some spots, and other times it's so burdensome and actually just prohibited blended funding from happening at all. So plus and minus all in one.
Great, thank you all so much. We are at time, so thank you for joining today. Thank you to our federal partners. We will be sharing the recording and slides, so be on the lookout for that. Thanks again for joining, and we hope to see you at the next NASTAD webinar. Have a good rest of your day.
Bye-bye.